So our second speaker is Professor Kaarin Anstey. Kaarin is one of the Deputy Directors of CEPAR, and she joined us, and when I say us, I mean us collectively, UNSW and NeuRA, as a joint appointment at the beginning of this year. She holds a professorial chair in psychology. She holds an NHMRC Principal Research Fellowship, and she's a Senior Principal Research Fellow here at NeuRA, and her team live just underneath this seminar room. Kaarin has spent, prior to coming back here, she was here briefly in the early 2000s, has spent a lot of her career at the ANU, where she has been and continues to be director of one of the Dementia Collaborative Research Centres, and also at ANU developed the Centre for Ageing Health and Wellbeing, and so she's come to us from that particular role. Kaarin has also had some major engagements with the WHO, particularly in the areas of guideline development for dementia risk reduction, and that's going to be the feature of her presentation today. So, Professor Kaarin Anstey.
Good morning, everybody, and it's great to be able to talk to you about what we've been doing in CEPAR over the last 7 years, bringing a lot of our research together in cognitive ageing. So I just wanted to talk about, in ageing, we often look at cognitive phenotypes, so where people end up with their cognitive function in late life. And we could look at normal ageing, which is where we'd like to end up, and there's even some research now on super ageing, so people who show no cognitive decline at all. We do find them in our studies. But then we have people who we'll see who are complaining about their cognition, but actually when we test them in our lab, we can't find anything wrong with them, and we might describe them as preclinical. Then we'll have people we see, and this is 20% of the population aged 70 and older, who have a mild neurocognitive disorder, or MCR, mild cognitive impairment. And that's actually much more prevalent than dementia, so that's the main cognitive issue in terms of just population numbers. And then we have people with dementia or major neurocognitive disorder, which causes the most disability. So that's if we just look at this at the end when people are very old. But what we like to do when we're talking about prevention is really take a life course approach and think, well, how do people, is this modifiable, and how do people end up in, at a particular spot? And when I started my research in this field, people thought there was nothing you could do to prevent dementia or change the trajectory that you were on, and the same for cognitive ageing. It was seen as sort of a fixed thing, and we used to study and observe cognitive ageing in studies without thinking it was modifiable. But now we know that there's quite a lot we can do to modify the trajectory of cognitive ageing and cognitive decline. And what we try to do is look at life course influences and hopefully stop people moving past a threshold where they actually develop impairment. So we spend a lot of time looking at risk and protective factors in late life first, and then as research has expanded, we started to realise that midlife was important, and now we're interested in early life and young adulthood. So all these factors, and even going back to childhood, we're starting to see that the whole of life is important for determining where you end up in terms of your cognition in late life. So what we've done in CEPAR, we've done a lot of work on risk and protective factors and looked at in cohort studies, and we've identified a lot of those factors. But this work in particular has a lot more policy relevance. So we've tried to look at the social impact of cognitive ageing in CEPAR. And this was led by a PhD student who's funded through CEPAR, Ashley Kimberly-Mitchell. We used the methodological approach from Barnes and Yaffe and Norton, for those of you who know those papers. They estimated the population attributable risk for dementia globally and for the United States and Europe, but of course Australia was not included in those analyses, so we've done this for Australia. We've also recently published the same analysis for Barbados and the Caribbean. And we found that within Australia, physical inactivity and midlife obesity account for the most population attributable risk of dementia. And after that, low education, midlife hypertension, depression, smoking and diabetes. There's a couple of important things here to note. The first is that with obesity, it's midlife obesity that increases the risk. And even midlife, being overweight in midlife has been shown to increase the risk of Alzheimer's disease, vascular dementia and all-cause dementia. But in late life, we don't find an increased risk associated with obesity. So that's quite a conundrum, and there are a number of these findings that those of us who work in the risk factor area really delve into and find that the story is actually a lot more complex than it might seem in some of the public messaging. So I just wanted to say another thing about this is important in terms of this information, in terms of planning population level approaches to prevention, because we want to get the most value for money with any population-wide intervention. So we'll pick risk factors that have the biggest population attributable risk, which is a combination of both the prevalence and the size of the effect. So there are some risk factors not on this list that have a very big effect, but they're very low prevalence. So we've also been interested in what the public know and what they think about their cognitive health in CEPAR, because we're interested in the social aspects of cognitive ageing. We did a national survey, the CEPAR Cognitive Health Survey, and we found that Australians in general, the protective factor they endorsed the most was brain training or keeping your brain active, mental activity. So in the population, about 40% of people think that you should do that. And then the other one that was very popular was heavy drinking. That was seen as a risk factor by the population. And then there were these other ones which were endorsed, so eating fish and doing crosswords and Sudoku, so fairly typical things. What was quite surprising in our survey was that less than 5% of the population recognised any of the cardiovascular risk factors like hypertension, obesity, diabetes. They were just not recognised by the population, and high cholesterol. Less than, I think it was like 1% recognised that. And then even more concerning was the fact that even when people did recognise risk factors for dementia, when we asked them about their intentions to do something about that, basically they had there was no association. They had a very low intention of changing their behaviour to reduce their risk of dementia. So you think, why is this? And we would obviously have to do more research to understand it better, but we think it's a little bit like superannuation. So most young people think, oh, super, it's when I'm old, why do I need to worry about that now? I'll just let someone else take care of it. I've got other priorities, I've got to pay for my mortgage, pay for school fees, whatever. So it's not a high priority, particularly for younger adults. So brain health isn't viewed as something that needs to be addressed. And I think that's a very strong message. It's something that we need to work on in this next stage of CEPARs around public education, and a number of, not just us, but obviously a lot of people in the dementia space are working on that as well. An issue that we faced in CEPAR, it's already been alluded to by John and by many others, is that in Australia we lack national prevalence data on dementia prevalence and dementia, and we've scraped together what we could from things like the National Mental Health Survey, which did include the mini mental state examination, but didn't include very detailed age data after the age of 70. And we did some work where we combined this with other estimates from international studies, and these estimates are still being used by Access Economics to develop their cost of dementia for Australia and things like that. It's still the work that we did, pulling these fairly general surveys together. So it's a real need in terms of population planning and prevention for Australia to get some good data, national prevalence data. So what about future work? We are wanting to improve our risk assessment tools, so we've developed some, and they're now out of date, and we need to update those tools, make them much more specific, and have tools for different population groups. And we need to look at gender differences in risk and protective factors and profiles, and age of exposure. There's a lot of work to do around risk assessment. With good risk assessment, we can then design good prevention programs. We've started to look at geographical hotspots. There's capacity to use a lot of administrative data to identify areas in the population where we would be expecting to see high rates of dementia based on things like GP databases where there's a lot of dementia risk factors. There's a lot of work happening in midlife risk reduction programs by our group, but many others. We're realising midlife is a critical period for intervention. We're also, one risk when we start talking about prevention is that people forget that you can also prevent cognitive decline in older adults, and even in adults with mild cognitive impairment, and even with dementia, the preventive interventions have benefits. Particularly people in that mild cognitive impairment phase who are at greatly increased risk of dementia. It's addressing the vascular risk factors and increasing physical activity are really important. So we don't want that prevention message to be lost on that group. We're also very interested in because this is such a big issue, there's so many people involved, the economic burden is huge, the needs for care are so huge. We're very interested in more looking at population and policy level approaches, not just individual risk assessment. So thinking about how to approach this at all levels in all sectors, nationally and globally, as we're working with the International Network on Dementia Prevention with that. And finally, to segue into the next talk, we're interested in developing for this next phase of CEPAR some tools to identify when older adults lack skills to manage their finances.